Good evening, everyone. Thank you very much for joining us. I apologize for the delay. We had a few technical difficulties, but everything has been sorted out now. Welcome to our webinar, Medrisk, in conjunction with Dr. Hlombe from Ethical. Just a few house rules. There will be no audio for the attendees. So if you do have any questions throughout the presentation, please just put it in the chat box. And we will, at the end of the session, we will have a Q&A session where we will pose the questions from the chat box to Dr. Hlombe, who can answer them for us. Just to confirm that this webinar will be with two ethical points, two CBD points. We will take the registration list from those that are attending and send it to the HBCSA for automatic registration with your against your names. And from there on, I hope you enjoy the presentation. I'm going to hand over to Medrisk CEO Jamal Ismail, who will then introduce our speaker.
Good evening, everybody. Thank you for attending. I won't take up much of your time because I do realize that it is quite late in the or late afternoon or early evening. And of course, you didn't come to listen to me. You actually want to listen to Dr. Hlombe. And of course, you also want your CBD points. So Dr. Hlombe actually needs no introduction amongst obstetricians. Those of you that don't know him, he is the medical legal advisor at Ethical. And he's one of the few medical professionals involved in medical legal risk protection or malpractice risk protection. He usually advises doctors, high-risk doctors such as obstetricians, on their practice and how to reduce their risk to malpractice exposure, considering the hospital environment that they're in. So without further ado, I'm going to hand you over to Dr. Hlombe. Thank you, Dr. Hlombe.
Thank you very much, and good evening to everyone. I'm just going to check. Great. Thank you very much, Jamal, and good evening to everyone. The presentation today is a very simple presentation. We're not going to spend a lot of time, but I'm hoping that we will spend a lot of time in the discussion section. Let's just have a look at Jamal. Yes. Basically, the discussion today will only be about the screening in obstetrics and gynecology. And I mean, the reason why we spend a bit of time talking about this, you will see in the presentation that some of the matters that we are dealing with, especially with antenatal screenings, are matters that, can be discussed and be sorted antenatally. Let's go to the next slide, then we'll talk about that. I mean, the objective is about what is it that you can do in the clinical care of a pregnant patient, and what are the risks that are there that you may need to look after for, successful defense and claims. But what we are saying is that what is it that doctors usually do that result in unsuccessful defense of claims? So we'll discuss that. Let's go to the next slide. Yeah, I mean, we as Jamal have said, we're from Ethical, and we've been in business now for 7 years. And what we have done in this presentation, we've looked at the ONGs that we have. So we've looked at a database of more than 750 ONGs in private practice that are spanning 2 decades. That is important because these are not the ONG cases that we've looked at are not just those that are with Ethical. It's the ONGs that have been in business for more than 20 years, where some of them are with us and others are with the other insurers. And we've looked at more than 4,000 notifications. But for us, we've been in business for just over 6 years. And we've looked at that from our in-house discussions, which is ourselves as clinicians, there's 4 of us, There are also 4 lawyers, and we always get the information from also the peers, that is the Ops and Gynae peers. So that's the data that we have that is based on this presentation. Let's go to the next slide, please. We even submitted a paper in the South African Medical Journal that really looked at these studies. What we've looked at is the notifications between the period 2009 and 2021. And I want to explain this. And this is a discussion that we always have with doctors. When I talk to doctors, they always ask, how many have you settled? And what we discuss is that settlement is the last bit when there is a claim. When there is a claim, it's either a letter of demand, meaning the patient demands something from the doctor, or it is a report to the HPCSA where the patient is complaining about something to the HPCSA, or there are summons. Summons are those things that really go to court. So what we've looked at this presentation, we just looked at settlements, those that went to court, and we decided between ourselves, the patient, and also the doctor that we are defending on settlements. Let's go to the next one. The number of settlements that we've had over the last 7 years, basically, for Ops and Gynae have been 69, right? And in the 69, this is something that is very important for us to understand. Gynae cases, there was 50 of them. Obstetric cases, there were 19 of them. And of the Gynae cases, those that were procedure-related cases, where maybe it was a laparoscopy that went wrong, where it was a hysterectomy, an abdominal hysterectomy, or other that went wrong, so we had 56. There is one that was a missed diagnosis on ultrasound, which is basically what we'll be talking about. In obstetrics, again, there were missed fetal abnormalities, there were 2 of them, and others were other matters that really we discussed, and between ourselves, the patient, or the lawyer representing the patient, and also the doctor that was involved, we agreed that, look, let's settle. So these were 16 of them that are obstetrics. The reason why I'm saying this is an important slide is because popularly, we as Ops and Gynaes, the information out there is the biggest risk is obstetrics. But the data we have and the amount of time and settlements are more in the Gynae procedures than in the obstetric procedures. And I will explain that as we go along. Let's go to the next slide, please. So these are the cases that were, settled. There were 4 cases of missed Down syndrome. One case was a failure to screen. Here is an important point here. Well, let me just look at the 3 cases first. The patient was not advised about screening. There were 3 cases. The patient declined screening. This is one of the most important things. The popular teaching is that, when you do your Downs screenings, what then happens is that if the risk is high, you then either refer that patient to a fetal maternal specialist, or you continue, doing your own further investigations. In these cases, what happened is that, firstly, the patient, the doctor failed to screen, and the patient came back, baby Downs, and when we looked at the records, there was just no screening that was done. And the patient said, if I were screened, if I understood, I probably would have taken a different decision. The second one was that the patient was not advised about screening. What does that mean? It meant that a gynecologist or an obstetrician did the screening, but the doctor said, because you are low risk, based on the biochemistry that we've done, we will not refer you or we will not inform you about the possibility of going to a fetal-maternal specialist. And the patients in those cases said, okay, but doctor said I'm fine. And if doctor, because I mean, those cases were like the lawyers said, you should have been informed. So those patients said, if I was informed, I would have taken a decision to go to a fetal-maternal specialist. The third one was a patient who declined screening, and the doctor have written down clearly and perfectly that the patient declined screening. But when we engaged the doctor and found out why was the case settled, it was interesting, in a sense that the patient said, yes, doctor discussed this with me and told me about it. The only thing that I didn't understand was how a Down syndrome baby looks like. And when I have a Down's baby, what are the implications for, taking care of the baby and all of that? So in that case, what the doctor then did was whenever he discussed the screening for Downs, he would have pictures, because the majority of people understand have seen babies or people who have Downs. So what they said is that in that case, the defense really, from a personal point and from ourselves, we felt, the doctor did everything that he could. But in terms of really saying that, look, the patient says, I didn't know how the Down's baby looked like. If the doctor had a picture, then I would be able to relate to people that I know who have Down. The one on spina bifida, again, this was a failure to measure the alpha-fetoprotein levels and to follow the necessary steps. This was again a case in one of the outlying areas in Bloemfontein. And when they said, when the patient came back and said, look, the doctor said, I asked this patient to come back for further investigations, and the patient did not come back. The problem there was that we did not have the records. And the patient on the other side said, I was not informed that I needed to come back. Let's go to the next slide, Jamal, please. So our experience really here is that from a gynae point of view, we had poor visualization of uterus wall with incorrect assessment. These are important because what we discuss in cases like these when it comes to screening on both sides, the gynae and obstetrics, what we advocate is, one, as gynae, you are probably better trained to do these screening tests. But from a legal point of view, the legal people will say to you, it needs to be done by a radiologist. In the first case where there was a poor visualization of the uterus wall, and there was a myoma that resulted in surgery in a young patient, that was a sad case. In that case, the legal system said, you are a gynecologist. You should have sent this patient to a radiologist, because from what we understand, it's the radiologists that actually are trained to do radiology investigations. Right? The second one, the failure to detect the Vectoral syndrome. That's again another case that is ongoing at the moment, where the way that the lawyers have put it is that was this patient sent to a fetal-maternal specialist? The answer in this case was yes, it was sent. Second thing was this patient informed about what you've seen in terms of the abdominal wall, in terms of the feet that were not properly developed? And the defense there was that, look, you can do the best you can. It's not always possible to actually pick up this particular syndrome. It's an ongoing case. But the reason why you are bringing it here is because the advice that we give to our doctors, I understand from a clinical point, but there's this legal side. When it becomes a legal matter, the legal people, they're just so fixated into saying, was a radiologist involved? As much as you as gynaes, you may say, maybe radiologists, some radiologists are not fully trained or would not pick up some of the things that you would see, because yourself, you would use your clinical history, you'd use your examination, and radiology mostly it's about confirmation of what you think this patient has, but the legal system doesn't work that way. So the advice that we always give is what they call defensive medicine, where you would really have to send them, even if you think maybe it's not really necessary. Let's go to the next slide, please. We talk about two medico-legal humps. And the first hump that you would see, this is what is normally out there in the public. You know, every time you hear about claims because there was missed downs, or there was gestational diabetes that was not managed well. There's so many things. Those are the claims. When we talk about, with birth defects, we say that is the first hump. It's the one that is out there in the public. But there's a second one, which we say the success or failure of litigation, it weighs heavily on this hump. Which is, let's just stick to that one, Jamal. Thank you. That is the hidden hump. This is where we come in, and when we engage doctors, we say, firstly, you've got to do your screening. And when you do your screening, you've got to inform your patients about the possibilities, the limitations of scans that you do. Maybe it's the body habitus of the patient. Maybe it is the lie of the baby. Maybe it's other things. And the important thing is not just to inform the patient, but in your records, you also write that this has been discussed with the patient. Secondly, all patients, irrespective of risk, all patients should be given the opportunity to be informed that we can refer you to a fetal-maternal specialist, even though your results, low-risk results. I understand, because in my engagement with a lot of obstetricians, they would say medical schemes normally would not pay for a fetal-maternal specialist if the risk is below a certain ratio. But from our side, we're saying, even if that risk is low and the medical schemes are not going to pay because of their own protocols, what we advocate is the patient must be informed, even if the risk is low, to say, if you really want to make sure, we can send you to a fetal-maternal specialist. So that is basically the second hump. That is the invisible hump, and that is the higher risk hump that we talk about. Let's go to the next slide, please. These are the guidelines that we normally say, please have a look at them. The SASWOG guidelines for private obstetrician, the competency levels. So that becomes very easy. The reason why we talk about these guidelines is because when there's a matter, even if it's an HPCSA matter, even if it's a civil or a summon, meaning this thing has to go to court, they go to these guidelines where they would ask, doctor, yes, we know you are a qualified ONG specialist, but here are the guidelines. Did you follow the guidelines? So we advocate that please be familiar with these guidelines when you do the ultrasound screening in obstetrics. So that's basically, they're freely available. Let's go to the next slide, please. Now, from our own observations, these are the problems that we have found, that are risks that are actually there that we really need to look at. From a record-keeping point of view, what we've seen, there were printouts that were shared with the patient, but the copies were not with the doctor. So we find a situation where there is a case and doctor does not have the images. When we asked the doctor, said, no, I print them out and then I give it to the patient. The patient has those printouts, but the doctor himself or herself doesn't have those. So what we say, if you are to give anything to the patient, give the patient a copy and keep the originals. That was the first thing. In the other case, what we said is that there was a time when in this case actually is that all the records on the machine were deleted because the IT person came in to update the ultrasound machine. When the person updated the ultrasound machine, everything that was on that machine, was deleted. So doctor did not have the records, but the patient had the records. So it was really a struggle to get the records when this patient actually took action against the doctor. There was a time when it said the hard drive ran out of space, so the images were not saved. We must remember that here, in order for a defense to really work, we need the records. Your records as the doctor. So whatever you do, you must ensure that you have the records. In another case, we said there was no backup at all. So this was a doctor that would see the patient, write the notes, give everything to the patient. And on the ultrasound machine, there was just nothing. And the doctor would say, I did the screening, but there was no record. There was no proof that the screening was done. I discussed this with the patient, but there was no record and there was no proof that actually there was a discussion with the patient. So it becomes very important when it comes to record keeping because that is what makes your defense better or our defending you better as the insurer. The other one was the lack of documentation on informed consent. Now, this becomes very difficult for us because we are saying that there was a lack of documentation on scan intervention, basic scans versus anatomy scans. That becomes important because, again, it's a communication between yourself and the patient, informing the patient that I can do level 1, level 2, or level 3 scans, but if you really want to do advanced level 3 scans, maybe you need to be seen by a fetal-maternal specialist. It's easy when you are practicing, but when it becomes a legal matter, it's a little bit difficult because lawyers just become fixated on that and say, scope of practice, this patient could have been sent to a fetal-maternal specialist for advanced scans. Scan limitations, as I mentioned before, in terms of say the body habitus, where the quality of the scanning itself, because maybe of your machine or the lie of the baby, those are the things that needs to be discussed with the patient, because some patients would say, I've paid for scans and I don't understand why now my baby doesn't have or has got club feet, or I don't understand why my baby has spina bifida. I don't understand why my baby has a upper limb that is not complete. Those are the things that you want to discuss and you record in your patient records. Scan limitations were discussed with the patient, and also reasons for declining screening. For instance, you do your biochemistry when you're screening for say, Downs. And the next thing the patient says, no, it doesn't matter. I mean, we will accept it because of religion or because of, it's gift from God or whatever the reasons for the patient is. Says, no, I don't want to go ahead, right? You want to record that there was a high risk for genetic abnormalities on this baby, discussed with the patient, but the patient declined further screening because that patient says, we will accept the baby as the baby is. You want to record that. The reason for that is we have found cases where patients, maybe conveniently, they forget that they said they will accept whatever outcomes, and they use that against the doctors. Then the other part that becomes very difficult is about competency, where you would say how much training you have yourself on the fetal anomaly scans. Do you need additional training? Do you need a fetal maternal certification to do it or not? It doesn't really make a big difference as long as you are able to record what you've said to the patient. Let's go to the next slide, please. I'm just going to run through quickly to these ones because these are current cases that we're dealing with. This is a case where we now have someone where a big baby was born. This baby apparently had gestational diabetes, or this patient had gestational diabetes, and it was delivered a baby that was 4.6 kilograms. And the reasons from the summons says this patient had diabetes. So there's a claim of 1.1 million. Let's go to the next slide. Now, this is what the patient is claiming. It says, oh, doctor did not manage my diabetes well. It's a high-risk pregnancy, and I had hypertension and diabetes, and you did not comply with the requirements in terms of managing my diabetes, right? Next. So obviously in those cases, then you appoint an expert, which is a peer. You ask that peer to have a look at everything. Look at antenatal records, you look at the intrapartum records, and you look at everything that happened. The plaintiff, that is the patient's expert, said, doctor did not interpret the CTG correctly. And therefore, the intrauterine management of this baby could have been prevented by a better standard of care from the practitioner. So that was the plaintiff's expert, that is the side of the patient. The side of the doctor said, look, the patient's problem was probably caused by poorly controlled maternal diabetes. Fine. But the question was, if a patient is a known diabetic, right, under treatment by her physician, and the patient assures you as the ONG that, oh no, my physician is managing this. What is your role? Do you want to look after that patient? Do you want to be involved in the treatment of diabetes? Or do you want to just focus on the pregnancy? That's basically the question from the defense side. Now, in the claim, they said what happened in that case was 1, big baby, 2, gestational diabetes, head cooling and a 4th degree tear. And I'm going to talk more about that 4th degree tear because as a big baby, there was a problem. That patient had to be pulled, right? When that patient was pulled, let's go to the next slide. I want to check if it's the same. Right, let's go back. Let's go back. I'm just going to just describe those points. That baby was born with poor Apgars because of fetal distress. And in that hospital, there were no head cooling facilities. This is a patient who was under distress, no head cooling facilities. The mother sustained 4th degree tears. And when the doctor looked at this patient, he said, immediately, let's take this patient for a cesarean section. Up to the theater, cesarean section, the anesthetist was not there. So they stood there for about an hour waiting for the anesthetist. So the question here has been, was this problem a doctor's problem? Did the doctor arrive and decided then on a cesarean section at the time when this patient could have had, or this baby could have had better Apgars? If the hospital had proper head cooling equipment, would it have made to the outcomes of this baby? Would this patient have had a 4th degree tear if really we went in and we did a cesarean section in time? If the anesthetist arrived on time? This case became even very complicated because when that baby was born was flat and the hospital did not have proper head cooling facilities, the baby had to be transported to another facility. And it happened in this case that that facility, that the transportation actually did not have proper equipment for those kinds of babies. So the question that comes here on this claim that we always debate is this the doctor's problem only? The biggest question here is that antenatally, did the doctor see that this patient is probably 4 to 5 kilograms? Is this a problem of screening? That's where now the arguments are at, which points to the topic that screening becomes the most, all these other problems about, poor Apgars, head cooling, the 4th degree, the anesthetist, may not happen if that doctor had presentation or preparation for an elective Caesar based on screening. Right, let's go to the next one. This is again another case that we're currently dealing with. Emergency Caesar for fetal distress, and the anesthetist makes a mistake. Instead of giving an anesthesia, a bupivacaine is injected into the spinal cord or into epidural area, cyclopentone. There was an adverse reaction. Ultimately, the patient died. Right? Now, the question is, what is the role of the obstetrician here? Because the summons just put the two together, said Dr. So-and-so was the obstetrician and Dr. So-and-so was the anesthetist. Right? Let's go to the next slide. They said this is a wrongful death. Second part that was very interesting in that case, they said the informed consent. One said, yes, it was a cesarean section, but look, I didn't know. That's the patient said. I didn't know that. Okay, doctors, you need an anesthetist. I would be used by, or the anesthesia would be used by, would be a GP with a diploma in anesthetics. And it spoke about the scope of work to say how far do doctors go? And the Consumer Protection Act, which is about the interesting thing in obstetric cases is that the majority of patients will know you as the obs and gyne. They will not know the anesthetist that is involved. Because in many cases, especially if it's an emergency cesarean section, they would not have had any interaction with the anesthetist because of the emergency reasons for the operation. And therefore, they will always want to take action against you as the obstetrician. What is important for us here, during the screening period, during the preparation, say for an elective Caesar, you inform the patient. You inform the patient that elective cesarean, I do the surgical part. There is another doctor who will be doing the doping part, which is the anesthetist, and that doctor, operates as an independent practitioner himself or herself, and is responsible for anything that goes in there. We normally get cases where the patient says, I only know Dr. So-and-so that has been taking care of me. Doctor did not inform me about the involvement of other doctors. So the informed consent part is one of the most important things that you do when you discuss with your patients and the involvement of other practitioners. We go to the next slide, please. This one is one that I've just spoken about. It was an interesting thing because that claim was initially a 55 million rands claim that was reduced to an 8 million rands claim. Let's go to the next slide. The questions there was that, why did you not detect the abnormalities prenatally? Was there a referral to a fetal-maternal specialist? This is a wrongful birth, because if you had referred this patient to a fetal-maternal specialist, we would have taken probably a different decision. But in this case, fortunately, I must say, the doctor, which is the obs and gyne, referred the patient to a fetal-maternal specialist, and the fetal-maternal specialist wrote a beautiful report that was actually there, and literature that was submitted, it says it is not a very easy syndrome that you would pick up antenatally. So the defense there from the peers that actually gave us the opinion, they said it's not something that you would pick up. What was more important was that the doctor had referred this patient to a fetal-maternal specialist. So we're a little bit positive in terms of the outcomes of this case. Next one, please. This is a death of a baby from a relationship between an obstetrician and an independent midwife. This we talk about all the time. This is a demand for about 9 million, where this patient had a ruptured uterus and the baby suffered brain injuries and died. In this case, independent, there's a big thing around patients want to have home births, want to have a more comfortable, birth. They get looked after by midwives. There's nothing wrong with that. We as clinicians, we know that the majority, especially in the public sector, of antenatal care is done by qualified midwives. The problem that we found here was that this was the patient that really wanted to give a home birth, and the independent midwife spoke to the doctor and says, "Doctor, if there's an emergency, can you be the doctor who is taking care of this patient?" And the doctor agreed, right? So this patient was induced at 41 weeks, but allowed to go home after being given Prandin. The next thing that would then was happened, the doctor was not informed that after giving Prandin just to soften the cervix, this baby was allowed to go back home instead of being monitored in hospital. So the baby was delivered by the midwife, and that baby came back. The placenta was not delivered, and the doctor had to do an emergency surgery. And the patient recovered fully, but the baby did not survive. Let's go to the next slide. So the question here was, the doctor would the doctor not was able to go and looked at in the antenatal care, the involvement of the doctor at that point, and the relationships with independent midwives. What is the contract? Is the patient involved? Does the patient know the role of the midwife versus the role of the doctor? And doctor, shouldn't you have had at least some interaction with this patient antenatally? Those are the questions that came from the particulars. What is more important in this case is that when the matter was brought in as summons, the midwife at that time had stopped practicing independently, was not insured, and the whole case was now the problem of the doctor. So what we normally say is that you must really be very careful in terms of your relationship with the independent midwives. Last slide. Thank you, Jamal. Yes, next one. Basically, what we are saying, adhere to good medical practice guidelines, develop a good relationship with patients, improve your communication, try and make joint decisions with the patient. Your medical records becomes very important. Informed consent is important. Your technical skill, technical skills, they come back to your experience in terms of screening. Do you do your screening? What level of ultrasounds that you will do? Always talk to colleagues, participate in multidisciplinary teams, develop an ability to refuse inappropriate procedures and do not overservice. I think that was my last slide. Yes. Thank you. I'm happy to take any questions.
Hi, Dr. Hlombe. We do have one question in the Q&A. Firstly, if I could just say to everyone, I know we asked questions to be posted in the chat. If I could just ask that if there are any questions, you'll obviously notice that you weren't able to post in the chat. If you could please post in the box that says Q&A. Dr. Hlombe, our first question from Dr. Ndaba. Why are the insurers always settling? Why can't they evoke Rule 41.1 that advocates a mediation process rather than litigation?
I think from an insurer point of view, you must understand that that rule on mediation is driven more by the patient or the lawyer that is representing the patient. We always advocate, firstly, even before mediation, we always advocate that let me start at the beginning. The relationship starts between a patient and the doctor. And that patient would choose you as a doctor for convenience or for referrals. That relationship starts there. When there is a problem, our message is, please, patient, talk to your doctor first before you go to the lawyer. But then if the patient has gone to the lawyer, it is the plaintiff lawyer or the patient's lawyer that in the summons, when we read the summons, they would say, no mediation. We understand, but in this case, we do not want mediation. And apparently, I'm not a lawyer, apparently the legal rules, when that lawyer from the patient side says, we don't want mediation, we cannot force mediation. So from our side, and I can speak specifically for us, we say, talk to the doctor first. Secondly, if really you are not getting joy with your doctor, find mediation. And there's a definition of how you would do mediation before you take it to the HPCSA, before you take it to the legal system, which is litigation from a civil point of view. But we are hamstrung in that sense that if a letter we get says we are opposed to litigation, apparently the legal rules is that you cannot force it.
Dr. Hlombe, the next question we have is, what level of aneuploidy screening is the minimum requirement to avoid negligence? And maybe I'll ask the third question as well. Why should I refer a low-risk patient to a fetal-maternal specialist? We will then end up referring all our patients, and that's from, as he mentioned his name, Dr. Kulula.
Yeah, just the last question. We are not saying refer them. We're saying inform them that you are low risk, but you have an opportunity to go to a fetal-maternal specialist, because we understand the limitations of that referral from a cost point of view. So we are not saying, and this is all because of what we've seen patients doing. Patients or lawyers, or when these are cases, they would say, oh, doctor did not tell me. You are not referring that patient, but you are giving that patient a different option. That patient will decide whether they want to go or not, and you record that, right? Because we've seen patients, doctors would say, no, but the biochemistry was low. It was less than 1 into 10,000 or whatever that ratio is. And, from a pathology, it says low risk. But baby comes out down. And the patient says, if I was informed that there was a way of detecting this, I would have taken a different decision. So we are now saying, just inform the patient, report in your notes that you've informed the patient, and the patient said, no, I'm fine, I'm not going there, right? That's a basic request that we have. That was the second question. What was the first question again, Jamal? I think you are mute.
What level of aneuploidy screening is the minimum requirement to avoid negligence?
I do not know. I really do not know. I mean, because let me put it this way. There is no foolproof way of avoiding patients taking action against you. So patients, you can do everything that I've said now. Informed consent, the screening was done, you followed the guidelines, there is an informed consent, your records are proper. There is no way that you can guarantee that patients are not going to take legal action against you. And when you say what's the level of aneuploidy that could prevent you from being found negligent, I really do not know. What I can tell you, the way that the legal system works is that, one, they will check, did you do what a reasonable obstetrician and gynecologist would have done if that person is in your environment? That becomes important. If you are sitting somewhere in Lusikisik, or you are sitting somewhere in Rush, or you are sitting somewhere in Ramakhale, and you are sitting somewhere in Sandton, or you are sitting somewhere in Pretoria, the reasonable standard is different in those different areas, right? So what is important for you as a gynae is, based on your context, you do the screening that is there, you inform the patient. For instance, we get cases here, let me not say mostly, let me give you an example. I should not have said mostly. Let me give you an example. We would have a case here from Mafikeng, And the question would be, why did you not refer this patient to a fetal-maternal specialist? And the answer from the doctor says, there is no one who is available around. That question is different if it's asked from a doctor who's seated in Pretoria or in Cape Town, CBD, or in Johannesburg. And if that patient who's seated in Mafeking was not referred to a fetal-maternal specialist, the doctor, the obstetrician, would not be been found that was unreasonable or did not meet the standard. But the one who's sitting in Pretoria with 4 or 5 fetal-maternal specialists, that one would have been found to have been negligent by not referring or informing that patient of the availability of that option. So at the moment, we cannot really say that what level of unemployed would be found to have been negligent. The most important thing, the patient must be informed, and that must be recorded in your notes. That works as a defense for you.
Dr. Hlombe, the next 2 questions we have is relating to mediation. And I understand you don't necessarily deal with the settlement of claims, so maybe we can also, I'll get some additional comments regarding mediation if needs be from the claims team, and we can take it from there. But the clause here, or at least the question is, if we have a clause that says mediation must be the first step if issues arise, that's signed at first visit. I've heard that some practitioners have started doing this. It was brought up also in a talk I attended given by a different medical insurance company that's relating to mediation and probably how enforceable it is. In the next question, I've also got somebody saying that the courts will always ask the lawyers to give reasons why they think mediation will not work. Is it true that if complainants say they don't want complainants say they don't want mediation, it ends there? They must give reasons why. So I'm not sure if you are the best person. I'm sure you will have an answer, but maybe I can also get some additional comments and send it to everybody at a later stage. But I hand over to you, Dr. Hlombe.
We should understand what mediation is all about. Mediation is when we feel like, let's talk about this and resolve before it gets to the legal system. And whatever decision we make it a court order, right? But let's discuss it amongst ourselves. We can have a representation, you can have a representation. We can hire a room where we can sit and discuss. That's what we do. And then we agree on whatever we agree on. That agreement then becomes a legal agreement, right? That is mediation, right? Now, in your take-on form, you can say to the patient, mediation would be the first step if you have a disagreement or if you are not happy. You can have that in your take-on form or in your terms and conditions of attending your practice. That is fine. We advocate that. Please have that, right? However, we've discussed this internally because we've seen it, because the doctors will come back and say, but why don't we go to mediation? The problem that we have there is our constitution says everyone must have access to the courts. Mediation is done before court. The decision then becomes a court order. Now it says it cannot be enforced. Yes, you can do it, but you can't enforce it because it is against our access to courts. So the plaintiff lawyers, the lawyers that are representing patients would have a look at this and says, we don't want mediation using the constitutional clause. It's just that I don't know it off by heart. I can just open the Constitution and say, this is it. Using that clause says, no, I want this thing to be discussed in court. I don't want mediation. And it's my constitutional right to go directly to court. We have had cases like that. That's basically the reason that we cannot enforce it.
Okay,
Kathleen?
thank you, Dr. Hlombe. The next question, firstly says thank you for an excellent talk, Dr. Hlombe. If you emphasize a level 3 ultrasound to a particular patient, a large portion of patients cannot afford the MAFU. Is that an acceptable reason to decline?
The minimum that the obstetrician should do is to inform the patient. Look, this is, the scan at this level. There are people who've got certification or who've subspecialized into doing more advanced scans. And in our area, if you have the person, these are the people that you can go to. But based on the assessment, you are low risk or you are high risk, but it's your choice. And again, it goes back to the Constitution, where the person has got to make his or her own informed consent about whether it goes or not. Here is a problem. Here is something that we always talk about. Patients sometimes would sell their shoes, would sell their cows, would do anything. Those that are really risk averse. So at the moment, the patient might say, I cannot afford the consultation. I cannot afford to pay the 7,000 rand to the fetal-maternal specialist. Don't take that as a point of not discussing with the patient. Give it to the patient and inform the patient that, well, you can do it. I mean, it's 100 kilometers from here. But from what we see, you are low risk. The most important aspect there is you record that discussion in the patient medical notes and the response of that patient. Because what happens and what we have seen is that maybe conveniently, patients tend to forget the discussions. They say, no, I didn't know. If I had known, I would have sold my house, or I would have sold the car, or I would have gathered the amount to go to the fetal-maternal specialist. The defense on your side is discussed, informed the patient, and the patient's response was, doctor, I'll think about it, or doctor, I will not do it. It's very expensive, or whatever the reason was. You don't force the patient, but you inform the patient, and the patient takes an informed decision.
Okay, perfect. Thank you, Dr. Hlombe. The next question is, the patients that abscond and only come back in labor, can we choose not to be involved because of the high risk of anomalies?
That's a difficult question. Okay, it depends. Firstly, the patients have got a responsibility to look after their own health after they've been informed. That is one. So if you inform the patient that this patient must come back for screening, come back for this test, come back for that, you've recorded that, and the patient does not come back, you cannot be held liable for a patient who's non-compliant, right? However, if that patient rocks up in casualty and you are on call, or if that patient rocks up in your practice, you've got an obligation to see that doctor, that patient. You cannot say, I don't want to see you because you were supposed to have come back 3 months ago, or you are supposed to have taken this, or you are supposed to have taken these bloods. You see that patient. However, you need to write in your notes that this is a patient I saw, informed the patient should come back because of these reasons. The patient did not come back, and I'm seeing this patient now at 38 weeks when she was supposed to be here at 28 weeks or whatever. But you then write your notes. You are not going to say, I don't want to see you.
Okay, the next question, Dr. Hlombe, regarding an expert witness. So it's a doctor that recently joined, not even, in fact, just over a year in private practice. and she has recently been asked to be an expert witness by one of the law firms more than once in her first year. So maybe if you can just comment on when does somebody qualify to be an expert witness, and maybe if I can just just talk about the second question as well, just for the sake of interest of time. The doctors asking patient relatives may have complaints, and you may at times receive it from multiple platforms, be it on social media, verbally, or by the hospital manager. When should one report a claim or a matter to ethical? So maybe just on this particular, the last question here, for all our doctors, we've also, in fact, as a freely available booklet, we've recently done at Medrisk, where we talk about when you need to report a claim to your insurer, whether it's ethical or anybody else, and that book is freely available. Dr. Hlombe, so the first one is about expert witnesses, and the second one is about reporting claims. Thank you.
I think the being an expert witness, there are two ways of looking at it. One is purely a legal standard. Purely from a legal standard, it says if you are a qualified, practicing, registered, the current registration as a specialist, ONG, you can be an expert witness. That's purely the legal standard. So I just need to be qualified, FCOG, MED, HPCSA registration, a specialist. I can be an expert witness. So that is easy from that point. There is a collegial part of it, colleagues. For instance, if you would take certain known, highly experienced obstetricians and gynecologists that probably some were your own teachers, some are you respect them because of their own experience. They tend to be the ones that we gravitate more to because of the number of years in practice. Maybe they are less in the private sector, they are more in academia, they are more in research, but they're still practicing, though we tend to say a number of times that you've really been working. But you can be an expert witness as soon as the HPCSA registers you as a specialist. That's a legal standard. So you will not be questioned. But your colleagues will question whether Hlombe, who qualified 2 years ago, now is an expert. No, you see? So that's what happened. So anyone who wants to be an expert, you must just look at your own competence, your own experience, your own skill versus many other people who've been out there working. The second part, in terms of reporting notifications, that's a very difficult one. It is very difficult because the way that we normally explain this to our doctors, we say, you are the specialist, you are the clinician, you've dealt with this patient. Therefore, your own gut feeling, will this adverse event or will this incident lead to a complaint to the HPCSA? Secondly, if you look at yourself, is there something that you could have done differently here that would prevent the adverse event? So we normally would say, you probably need to look at it. There are things that are very clear. Maternal death needs to be reported. And intrauterine fetal death needs to be reported. But a 4th degree tear, does it really need to be reported? You need to weigh that from your side, because these are things that would happen on a regular basis. It depends on the way that that patient would have responded, right? But any perforation, say it's a gynae procedure, any perforation, any extended stay in hospital, be it an infection, be it a perforation, be it a different reason why this patient sits in the hospital for an extended period, you may want to report that. But we normally go back and say, you use your own gut feeling in terms of the relationship you have with the patient and knowing, is this a routine thing or, is it, for instance, the question that I get asked a lot is, do we report premature babies? Do we report babies with low Apgars? I normally say, look at the total context and decide if this is reportable or not. Then you report that. But from a risk management and the risk averse point of view, we normally say, if you are uncomfortable, report it. So there's no straight answer from this.
Okay, so the second last question, and then, is a referral to a sonographer for a fetal medicine scan when a patient cannot afford a fetal medicine specialist acceptable as an alternative? Also, if they do not sign that they refuse screening, but you have recorded in your notes, is that sufficient? Or should we make them sign? I'm assuming that you can't force the patient to sign, but I'll leave that over to you.
Yeah, you cannot force. What we normally say is that it works better to have an informed consent where they sign refusing to go to a fetal-maternal specialist. It works better. However, understanding the practice, understanding the operations of a practice from a clinical consulting examining point of view, your defense there is your notes. If you've recorded it in your notes, discussed, and the patient for these reasons says, I will not go, it works well as a defense. So it's not really required that there's an informed consent in terms of refusal. It's not absolute requirement, as it's an absolute requirement for a procedure. For a procedure, it's an absolute requirement. You must have informed consent. But a discussion in terms of referral to a fetal maternal specialist or a sonographer or that, and the patient refuses, you record that. That's the minimum you can do. If you have an informed consent where they can sign, even better, right? So that side is covered by your notes. The second point is that, referrals to a sonographer, it's again on your records, because the results from the sonographer that you would take and you put in the patient file would act as your defense, because, again, from a legal point, they say those are radiology trained people or ultrasound trained people. They are experts in that field. You are not really an expert in that field. So you can use their results properly, and you can use that as a defense that based on the sonography, the ultrasound specialized person who is not a radiologist, that person, based on their report, then you are fine. I know of areas, towns within South Africa where they say, we do not have a fetal maternal specialist, but we've got a sonographist that we refer our patients to. Says, that's good enough. And the report that you get there, it is fine. And you refer the patient to them. And you record that in your notes.
Perfect. Thank you, Dr. Hlombe. And then our very last question. Could you talk briefly about availability or lack thereof, anesthetic services for emergencies? The 1 hour delay with getting anesthetic services with that macrosomic baby you alluded to earlier is concerning. How can this risk be ameliorated?
You see, that's a very, very difficult question. And I tell you the reason why it is difficult. I think the people who are attending here, they know how anesthetists work. Anesthetists, they mostly work from their own rooms or from their own cars. Anesthetists don't normally have a contract with a hospital where they have consulting rooms, meaning their availability is not managed by the hospital in many cases. So the way that most anesthetists work, they would say, I do a lot of neurosurgery doping. And therefore, I've got 5 doctors or 6 doctors that I know that when they have their slate in theater, I'm available for them. It's the same with obstetricians. You would find that you as an obstetrician or a group of obstetricians would have an agreement with a group of anesthetic practice or a anesthetist. So those are private arrangements that you do. So the hospital itself may not have control over the availability and may not guarantee that there is an anesthetist, because the anesthetists don't normally contract with the hospital like you having rooms in a certain private hospital. So the most important part for you is to have a proper written contract between yourself and the anesthetist or the anesthetic practice to say, when there is an emergency, you will be able, as this anesthetic practice, to be available within a reasonable period. Or when I have a slate on a Thursday morning, you are my anesthetist and you need to be there. If it is written down properly and you have a contract and the patient or the anesthetist is not available, then that anesthetist would have breached that contract. Then it becomes easier if there is a case you want in terms of the unavailability. Then you are able then to have a nice discussion with that anesthetist if there is a matter. So my point here is that it's more a solid contract or agreement between yourself and an anesthetic practice that has got several anesthetists, or 1 or 2 anesthetists that you know that you work with. What we have seen is that a lot of obstetricians have contracts with independent anesthetists. They'll know that, no, I work with Dr. So-and-so. I'm the one that is there when the doctor has a slate, and I'm the one who's covering that doctor for emergencies.
Thank you, Dr. Hlombe. So we actually came to the end of the program now. Firstly, I would like to thank Dr. Hlombe for making himself available. I know it's close to 8 o'clock. There's many other things you can do other than speaking to doctors. And those of you that have interacted with Dr. Hlombe previously will know that he's always available and always ready to assist. And then lastly, I would like to thank the audience, the obstetricians and the other doctors in the audience. You could have also been anywhere else. You could have having your meals and you're spending time away from your family. And from our side, we wish, at least hope, that this was informative and we've learned something, because the aim, of course, is to minimize risk, and that's why we brought this talk to you. And if there's any further questions at any time, feel free to reach out to me. And this booklet that I spoke about earlier, we'd make that available on the chat, and I'm not sure, but yes, in the link there's a chat actually. In the chat is a link to this booklet, and there's about 5 chapters on. There's a very short booklet. You can read it within half an hour. And one of the important chapters in there is when must you report a claim. It's just guidelines, because one thing, because we do notice a lot of doctors do report incidents late and are not sure what to report. And so this will actually will equip you better. And if at any time there's any further questions, just please feel free to reach out to me and my team. Thanks a lot, everybody. Everybody, I think one more question came in. Can I just, Dr. Hlombe, can I just ask this one question that just came in now? The one person asked about 4 questions so far. Or does that theatre availability for emergencies in one covers casualty, etc.? So as in a on-germ, on-call impact the doctor, if poor outcomes while awaiting for staffing, a problem we face now and then.
I mean,
repeat? Yeah.
Look, these are the matters that we normally deal with. And again, it goes back to what you would write. Let's take an example. Here's a patient in labor and emergency cesarean section is indicated. And you say it to the midwives, you say it, prep, let's go immediately to theater. Then you go up to theater. The theater is managed by the hospital. You wait. The staff is not there. And you wait. The most important aspect there is the notes. At this time, this patient, it was fetal distress, emergency cesarean section, took the patient up to theater. Staff were still being collected. Theater was not ready. You have no control on that as the doctor, right? But here is a point. When the summons come, you will be, let's understand it from a patient perspective. Patients do not know this artificial difference between doctors, the hospitals, and the nurses. They just think that we are all one big group, and patients know you. So what patients do, they will say, maybe my baby would have been saved, or the outcomes would have been better had the doctor not delayed getting me into cesarean section. But your notes as the doctor, when this now gets to the lawyers, when the notes are there and when we look at the notes, we then say, no, man, doctor waited there for an hour. And it's beyond doctor's control. So the most important part there is your own records, because you don't have control on staffing and the change of shifts and the amount of time that they have to be in the hospital. All you want is emergency Caesar, the theater is ready. If that theater is not ready and the patient has got bad outcomes and the patient at the end has a claim against you, your notes are the ones that would say, maybe the hospital needs to be part of this case.
Okay, thank you, Dr. Hlombe. So we're going to end off here. So thank everybody for attending. And yeah, again, like I mentioned earlier, if there's any questions, please feel free to reach out to us. Enjoy your evening, everybody.
Thank you. Thanks, everyone.